Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health finance and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about chronic pain and interventional treatment methods available to people suffering from it with Dr. Magid Guirguis. In the second half hour of our program, we'll be taking your questions live by phone, as we always do, at 504-866-3200. That's 866-3200. And by email. You can email your questions to us right now at hhquestions@wlae.com, and we'll have that phone number and email address at the bottom of our screen during the second half of our program. Tonight, we welcome Dr. Magid Guirguis. Dr. Guirguis received his medical degree in Cairo, Egypt from the Faculty of Medicine at Ain Shams University. He also completed his internship and residency at Ain Shams before eventually arriving in the United States. He settled in Cleveland, Ohio, where he completed his residency in anesthesiology and his fellowship and research fellowship in pain management at the Cleveland Clinic Foundation. Dr. Guirguis is a member of the American Society of Anesthesiology and the American Society of Regional Anesthesia and Pain Management. He is a pain management expert, and we are pleased to welcome to the program Dr. Magid Guirguis. Nice to have you with us.
Thank you, Tom. Thank you for having me today.
Yeah, well, talk about your journey from Egypt to the United States, and tell us who was it or what was it that first got you interested in medicine?
So I think the greatest influence of me picking medicine as a career was my mother. She was a physician, and I think through her stories regarding her patient management every day and the complexity of cases that she used to see made me really attracted to medicine and decided to pursue this as a career. I started back in Egypt in residency in internal medicine. Through the whole residency, I think I was focused more of pursuing a fellowship in cardiology at that time, but I found myself developing a special interest to chronic pain. At that time in Egypt, chronic pain was not recognized as a subspecialty, and it was up to the internist to diagnose it and find a way to treat it. So that made me expand my readings regarding chronic pain, and made me also go and pursue a research fellowship in Cleveland Clinic to understand more about the specialty. And through this fellowship, I actually worked with some of the pioneers in chronic pain management that attracted me so much towards the field to an extent that I decided that this is what I want to do, and that's what I want to make as my career.
I would imagine it's a very rewarding field of medicine to take people who are in constant pain and make them feel better.
Absolutely. I mean, I think it is the most rewarding part of medicine in general, but if you're dealing with pain, that's, I think, an extra reward, especially when your patients come in and said that they were able to dance in their daughter's son's wedding, or they were able to play with their grandkids for the first time. I mean, that makes me as happy and excited as the patient when I hear those stories, because it's, for me, that's what the career is all about.
All right. Well, before we get into the details, I want to start from 30,000 feet. People watching tonight saw the topic, chronic pain. Boy, I'm sure hoping the doctor's going to be able to tell me something to make me feel better. Is there hope in this area? Are there new treatments, and are there new treatments coming?
So I think about chronic pain as a it's not a recent subspecialty, but it's comparably very recent. And I think there's a lot of research, and there's a lot of things to discover as far as the diagnosis and treatment of chronic pain. So I think there's a lot of promises in the future, and I think with doing more extensive research about chronic pain, there would be better modalities for diagnosing the disease and figuring more about the cause of that, and also inventing either newer techniques or procedures for management of chronic pain.
All right, and at the end of the program, we'll talk about what the doctor sees coming down the line. So let's start with a definition. What is chronic pain, and how does it differ from acute or post-surgical pain?
So by definition, chronic pain is defined as persistent pain that would be persistent more than the expected duration of a disease or an injury or a surgery. And the cutoff number is usually somewhere between 3 and 6 months, where the pain persists more than that. We really consider that as a chronic pain. The difference between chronic pain and acute pain or post-surgical pain is that the acute pain is well-defined, shorter in duration. The response to treatment is kind of like expected, and it's either resolved with medical management or changed to chronic pain. So as far as chronic pain, I think recent research from Johns Hopkins actually showed that about 1 in every 6 Americans complain of a chronic pain condition at a certain point in their life. And when calculated the cost in the U.S. alone, it showed exceeding cost of $100 billion between treatment of chronic pain or days lost at work or disability. So that gives you an idea about the in-depth and the seriousness of that condition, and that's why we do what we do.
I didn't hear you mention the word severity anywhere in the definition. Can chronic pain be mild?
So by definition, when the pain persists, we consider it chronic pain. And the perception of mild, moderate versus severe pain is really a subjective perception, and we take it in consideration while we're doing the treatment. But I always think about what is the pain not enabling the patient to do. So I always think about the functionality, and restoration of function is our main goal of the treatment. So patient might perceive the pain being very severe at the beginning, but once the patient recognized that he was able to do more in function, that whole perception actually changed. But we still categorize it based on mild, moderate, or severe.
Okay. Some of the most common conditions that can often lead to chronic pain. You brought along a pretty long list.
So I would really sum that list in the upcoming slide. I would actually sum it between back pain that might be related to a disc herniation condition, or bulging disc causing stenosis around the nerves in the back or causing a pinched nerve. Also some syndromes related to back surgeries or pain after back surgeries. Other conditions related to chronic pain which are related to nerve pain, and that might be related to diabetes, might be related to cancer, and sometimes nerve pain can happen idiopathically or actually happen without a cause. And those are the causes that we're going to discuss separately and discuss about the modalities of treatment. So starting with back pain, there's multiple causes for back pain. The most common is a herniated disc that actually might cause a pinch on a nerve, and the term sciatica is very common that people present with. It's usually not always the sciatic nerve, but it can be a pinched nerve anywhere in the back, starting from the neck all the way down. And sometimes also another disease that can happen because of the slippage of a disc, which is spinal stenosis, which means that it's not a particular nerve that's pinched, but it's the whole spinal cord in the back that the canal it passes through is actually narrowed. And it might happen because of one disc, and the majority of the time it happens because because of multiple discs. And that's a very small example of some condition that's caused back pain.
Okay, let's talk about interventional pain management and how you utilize those techniques in your work. So
interventional pain management is a minimally invasive procedure management that actually fills the gap between conservative therapy and more invasive surgeries. Usually the patient that we pick to go this route or have a minimally invasive procedure are patients who either were not relieved by medical management or physical therapy, or patient who could not handle the side effect of the medication, or patient who actually decide that it's time that I would stop taking my pain medication. There might be a procedure that would help me to continue without any medical management or very, very small medical management.
Okay. In terms of modality, what are some of the more common methods of treatment that you would typically work with interventional pain management?
So the most common procedure that's done in pain management is actually an epidural steroid injection. And the epidural steroid injection is literally a procedure where through X-ray or landmarks taken by X-ray, we deliver a needle just between that herniated disc and the pinched nerve, or just before the spinal canal to deliver steroid. And the whole idea of that, the steroids would decrease the irritation or the inflammation around those nerves. And this procedure usually helps the patient for starting from 4 weeks, sometimes up to 6 months, or maybe a year. Other common condition that also cause pain in the back is arthritis. And a lot of people have pain in the small arthritic joints between the vertebrae, which are called the facet joints. And that's very common. We see that every day. And for this kind of disease, if you can see in the next video, we offer actually either injection in those joints, which is very similar, like steroid injection, like in any other joint, or newer modalities came where we can either block or ablate, kind of like destroy the nerves that supply the pain sensation to that joint using radiofrequency techniques. Usually those joints regenerate back again, and these procedures are repeated, but they are known to cause relief for somewhere from 6 months up to 2 years. And it all depends on the radiofrequency type used. And that's very promising, looking that patient would repeat one procedure every year for the arthritis. And that's one of the modalities of treatment of back pain.
Patient awake during these procedures, and is the patient giving you any feedback saying, ooh, that's the spot, perfect?
So usually for the initial test where we actually block those nerves, we keep the patient calm. I mean, either people sometimes use no sedation at all because we use very small needles and we numb the skin very well, or we use minimal sedation. During the radiofrequency ablation, it's important for the patient to be more comprehensive with the physician, because we test where those nerves are, we send some electrical signal, and we really imitate the pain for the patient before we decide to ablate those nerves. So we kind of like stimulate those nerves before deciding that we're gonna destroy them using radiofrequency heat. So I think this procedure, the patient is more communicating with the physician. Once we decide on the burn, we can give sedation or not sedation depending on case-by-case basis.
Okay, and what's going to help determine the success rate of these procedures we've just talked about, and in what percentage of the cases are they successful, where the patient gets real relief?
So the help to determine if the radiofrequency ablation, specifically that procedure, is successful is doing a test before it, where instead of actually going and deciding to destroy the nerves out of the blow, we decide to numb them first. And we send the patient to, if the patient was not already enrolled in physical therapy, but I give them a pain diary and I ask the patient to do as much activities as they can. In that duration I'm testing, I would see more restoration of functionality. And if I see more than 50%, I would know that the RFA would be successful, and I discuss with the patient that that's what you expect for up to 6 months of relief. And the success rate usually with that test being successful, the success rate is very high. Regarding epidural steroid injection, I mean, This one, really, it's a series of couple of epidural that we usually give to the patient and follow the patient up after the series. The majority of the population receive about a series of 3, and the success is somewhere between 70 to 80% relief from the back pain for a duration between 3 to 6 months.
Okay. And how do you know where to hit? What tools are you using to make that predetermination?
So it depends on, I mean, a good physician can tell you which nerve based on the symptoms the patient present with, especially if it was a pinched nerve or a radicular pain. Sometimes if the signs are a little bit vague, we depend on the position for MRI. And usually if MRI coincide with the symptoms of the patient, that's exactly when we know this level is the one that's affected. And for that, sometimes we do specific epidural treatment, which is called transforaminal epidural, where we actually inject in front of that nerve. I mean, it's more, if you think about it, a classic epidural is like a shotgun. We're gonna divert the steroids everywhere in each level of the back, or at least 2 levels above the injection and 2 levels below, where the transforaminal is more of a sniper shot towards the nerve that's affected by the patient, or the nerve that is where the pathology is happening.
We often on this program talk about the teamwork approach and the team approach to things. Are there times you're working with an orthopedic to decide on what is the best treatment option and where the treatment option should be?
So actually we work very closely with either orthopedic, spine surgeon, neurosurgeon, and sometimes it is really a targeted treatment where the neurosurgeon think that's where the problem is, and he actually send the patient for that particular injection, determining the level, which sometimes also help the surgeon to determine if the surgery is going to be more successful if done. Also, it sometimes helps the surgeon to know the level of the surgery, if there is more than one level involved. And we communicate very well. I mean, also, the last resort, if those conservative therapy failed, is me sending the patient to the surgeon saying, I think that we consume conservative therapy. Right now it's time for major surgical management.
The next step. Let's talk about vertebral fracture and what that could mean for someone and what types of pain management treatments are available there.
So the causes of vertebral fracture might vary. It might be a simple cause like patient falling off and fracturing a vertebra like any other bone in the body. Or it might be more complex, actually, showing as a cancer or metastasis from cancer. Some diseases in particular, which are endocrinal diseases, causes weakness of bone, like osteopenia, that might weakens the bone to an extent that the bone sometimes fractures by itself. I mean, I had a lot of patients that suffered from osteopenia that mentioned that they had a fractured bone when they just bent it to pick something from the floor. And they never saw that this would really break your back, and the reason is that the weakness of the bone. So what we offer as treatment-wise for those kind of compression fracture, what we call them, is we offer a procedure called a kyphoplasty, which we can bring a video to show. I mean, it's a very neat procedure where we insert needles in the compressed vertebrae. That's done it's usually done under X-ray guidance. And we insert those needles, we enter that fractured vertebrae, and through those drill hole needles, which are, as you can see in the video, very small, we insert a balloon. And the whole idea of the balloon is to restore the height of that fractured vertebrae, which has been lost. And after creating that small cavity with the balloon, we retract the balloon out and fill that cavity with cement, so the vertebrae become more strong and not subjected to fracture afterwards. It is particularly important for the thoracic vertebrae or the mid-back vertebrae, because any fracture can heal within a year, but it would never restore the height. And what I tell my patient all the time is that if it's involving the thoracic vertebrae, if it healed, they would end up with an arched back. And that's a problem when that really is nearby the lungs, because that might cause a lot of lung problems that's actually become more of a problematic than the fracture itself. And there are some reported cases that people actually went to fatality because of those compromised lungs. They had multiple fracture and they had very, very hard time breathing.
Our guest tonight is Dr. Magid Guirguis. Tonight we're talking as pain specialist, pain management specialist, chronic pain management specialist. And tonight we're talking about easing that pain for patients. Chronic joint pain is an issue for a whole lot of people. What methods of treatment do we have for chronic joint pain?
So chronic joint pain caused by osteoarthritis is a very, very common problem. I mean, it's the most common or the most common presentation that we see in clinic. At least, I think, per recent research, about 40% of adults come to a primary care physician with the primary complaint of pain in the joint. And majority of the time, it's related to arthritis. So there's multiple treatment offered for pain or joint pain due to arthritis, starting from comprehensive management or physical therapy or medical management, up to procedure, and that's where pain physician comes handy of injecting those joints with ultrasound or with X-ray and doing steroid intra-articular injection. Those joints start from your back, as we discussed with the facet joint, or joints involving the tailbone, which is the sacroiliac joint. Also the knee joint, which is actually a very common problem, people having arthritis in their knee, and for which we offer injections, and we offer ultrasound injection done in office. New modalities has come up for joint pain, particularly the knee and the hip joint, where we can also use the same radiofrequency technology in ablating those nerves around the knee. And you can see that we can insert a couple of needles around the knee and use the same way of ablation or burning of those nerves.
Here's the video.
And if you can see, it's only 3 needles that we inject, that we place around the knee joint, and we ablate those 3 nerves. And case report has shown people getting relief somewhere between 6 months up to 2 years from that procedure. We usually keep that procedure as a last resort for people who cannot have a knee replacement, either due to a heart, lung condition, or due to age. And that comes to be a saver, because those people suffer a lot from side effects from medical management, and they would not have the surgery because of their comorbidities.
This sounds like a whole lot less aggressive, though, than a total knee replacement. Why wouldn't I start with this?
But it would not replace a permanent treatment like a knee replacement. And I always tell my patients I would keep that if you really can have a knee replacement. Now, new research has been coming out for knee replacement pain that actually happened after the replacement, that this modality have worked to control that pain. And these are a couple of case reports that came out, and I'm hopefully we're trying to do one of our own Ochsner studies for that particular procedure, which is called the genicular nerve RFA, hand in hand with some orthopedic physician in our system and in LSU, to see if there's any long-term complication out of that procedure.
Okay. In what scenario would you recommend something like spinal cord stimulation, and how can that benefit someone with chronic pain?
So spinal cord stimulation or neuromodulation is a device or a way of managing pain that might be either related to a surgery in the back that was initially done for a herniated disc, that after which the patient is not weak anymore but still suffer from pain, or either due to a nerve pain, which might be idiopathic for a common condition called CRPS, might be due to diabetes, or sometimes we do it for cancer pain or nerve pain due to chemotherapy giving for cancer patient. The idea about this device is insertion of two small electric wires in the spine through a needle insertion in the beginning for a trial, where we put them in the back, and we can see also in the next video the technique of placement, where we keep them on the spine or the spinal cord, and the whole idea of those wires send an electrical signal which distort the pain signals that's coming from a particular place in your body to the brain. So although the cause of pain is still there, the patient perception of pain is much less, or we kind of like distorted that perception.
You're fooling the body.
Exactly. What I tell my patient usually most of the time is that let's fool the brain to make you more active, and by being more active, we're going to restore a lot of other pain that you developed because of that condition that we can't treat. And
back to functionality, which is what you talked about at the very beginning.
And it's all about really functionality. We measure functionality of people before inserting that device, and then after inserting the device. In the results are really surprisingly good, and that's one of the modalities that neuromodulation was built on.
Okay, I saw a control model there in the video, or control packet. Is that something that's inserted into the body? Is that separate? So
for the first procedure, which is the trial procedure, which we do in like a minimally invasive procedure, patient go home the same day, we give the patient a programmer, and we try this for somewhere between a week to 2 weeks. And the patient, through multiple programs, can change one program to another program to see which one actually distort the pain signal better or makes him functional better. Once we settle on a program and the patient is happy with it, then when we do the permanent surgery, we insert this device in the body, and that can be controlled wirelessly to change the program or recharge the battery without having anything outside the body.
Is that controlled by the patient or controlled by the physician?
So the charging is controlled by the patient, but the reprogramming is usually controlled by the physician. There are new devices that are coming out that would give patient multiple options to pick from, but really not to take over the whole programming.
Okay. You've talked quite a bit tonight about destroying nerves. I'm assuming the nerves are there for a reason in the first place, although they're not making the patient feel very good. Any downside to destroying nerves?
So the techniques I discussed about destruction of nerves are not permanent destruction. The radiofrequency ablation is actually heat destruction, or if you can say, cutting of a nerve. Now those nerves regenerate, and it all depends about how good was the cut or how good was the radiofrequency ablation. So that means that you would like very good anatomical landmark to place your needle, very good testing. And the other thing is how much your nerve grow. The speed the nerve grow from one person to another is different.
And they do grow back.
They do grow back, and that's why we have to repeat the procedure. Now there is other procedure that we do sometimes for cancer pain, for which we try as much as we can. We ablate those nerves completely. I mean, we try to destroy the nerves as long as we can. And at that point, those people usually have terminal cancer, and there's not a lot of downside of destroying those nerves, but you're trying to get those patients some relief, and that's a different procedure.
All right. There are some other root causes of chronic pain. We'll talk about those in a moment, but first we want to invite you to call us right now with your questions and share your stories. 504-866-3200. 504-866-3200, or you can send us questions by email. We're always happy to take those too at hhquestions@wlae.com. And again, the time to call with your questions is right now. Doctor, what are some of those other root causes of chronic pain that we haven't discussed yet tonight?
So there are other causes of chronic pain, and one cause I always think about that is between chronic pain management, neurology, and other practitioners, chronic headaches, and that's also a very common problem, and for which we can offer multiple nerve injection, which can either also be done under ultrasound or under X-ray. We can offer Botox injection, which can help with migraine headache. Other cause of chronic pain that we see a lot in our clinic is abdominal pain, and that might be related to multiple causes, starting from muscles, nerves, unfortunately sometimes a cancer, and we offer a lot of modalities of treatment between nerve injections or nerve ablation or destruction or muscle injection or actually spinal cord stimulator. And one other very common pain that we see in the clinic is pelvic pain, either pelvic pain in male or female related to pelvic conditions, or also due to the same thing as abdominal pain related to a cancer or an injury or a surgery done before, where we offer the same thing. We offer either nerve injection, ablation, and newer modality actually is doing the spinal cord stimulator for pelvic pain, which is showing a lot of success recently using new programming for the spinal cord stimulator.
All right. Well, we're going to take a break now, but again, your questions coming next at 504-866-3200, 504-866-3200, or email us with your questions at hhquestions@wlae.com. And later in the program, at the very end, I'm going to ask the doctor for what he sees, where we're headed 5 to 10 years from now if I had him back on this program. So we'll look into the future a little bit too. Hello Health, your questions next in just a moment.
We can beat this. The spill in the Gulf, it's a catastrophe.
But we will solve it.
This is not a Gulf Coast issue.
This is a national problem that requires a national solution.
But what can you do to help?
What do you have to offer? Your voice.
Speak up.
Add your name to the petition
Demanding restoration and protection
of America's Gulf Coast.
Sign it.
Share it.
Be the one.
Be the one. RestoreTheGulf.com.
You're watching WLAE, New Orleans Public Television. Find us on Facebook and follow us on Twitter.
All right, couple of quick notes before we get going. One, happy birthday to the Marine Corps. I don't know if you knew that today's the birthday of the Marine Corps. Just celebrated that earlier tonight. And then also, you cannot call about the pain caused by the St. San Francisco game or the LSU game, although if you're like us, it caused lots of pain. Lots of people around here, too. But anyway, let's get right to your questions. 504-866-3200. Lots of people holding already for Dr. Magid Guirguis, chronic pain specialist. Let's start in Covington. Line 4, Ray, you're first, and welcome to Hello Health.
Thank you, Tom. I appreciate it. How you doing, Dr. Guirguis?
Hi, Ray. How are you?
Good. You just last Friday did a SI injection for me, and it is working beautifully.
Okay.
And I'm watching the program, and you're talking about the facet injections, which I've had done, gave me some relief. Then you suggested going to physical therapy, helped out a little bit. But then you did the, radio frequency ablation, and that has helped my back out tremendously. And then Friday, when you did the SI joint, this is the best that I have felt in a long time.
Okay. I'm happy, Ray. You had great relief, and and that is what we're trying to do. And thank you for calling. I mean, any questions for me regarding any other conditions that we discussed today?
I'm sorry.
Any question, Ray? Do you want to ask regarding conditions that we discussed?
No,
today?
I don't have any questions.
Okay.
I just
very good.
Just tell people, go ahead and take care of your back and listen to what the doctors have to say. And I'm going to tell you,
okay,
it works, and hopefully I don't need anything else, at least for a couple of years.
Yeah. Ray, I'll ask a question for you. So exactly what did he have? What did you do for Ray? And how long can, Ray's very happy, how long can Ray expect to be happy based on, what you've seen from other patients?
So it was a common, problem, which is facet arthropathy, which was the major problem that we tackled with injection. Then we went in and did the radiofrequency ablation or ablation of those nerves. And afterwards, Ray did have relief from those, and we started moving down to where the arthritis is in the tailbone or the sacroiliac joint. We injected those in expectation of relief from the radiofrequency ablation somewhere between 6 months to a year, and from the SI joint injection somewhere between 3 months to 6 months. And if that was a repeated process, we can also do ablation of the nerves for the SI joint.
All right. Well, Ray, we're very happy that you're feeling better, and thank you for calling and sharing your story with us tonight. We appreciate that. Let's go to line 5. Helen is next in Kenner this evening. Helen, welcome to Hello Health.
Oh, thank you for taking my call. Dr. Guirguis, my L4 has a slip forward. Oh, I thought...
No, go right ahead.
Go ahead. Go ahead, Helen.
Yes, thank you for taking my call. Dr. Guirguis, my L4 has slipped forward in respect to L5. I have a 6-millimeter anterolesthesis, and in the past they have suggested a metal cage with screws, and I don't like the idea of screws in my spine. So is there any minimally invasive procedure that could help the anterolesthesis?
Okay. So, Helen, it's dependent on the anterolesthesis. So anterolesthesis is a slippage of a vertebra, or what we call is, stability of the back is kind of lost where two bones, one of them move anteriorly or to the side, and anterolesthesis would mean that the vertebrae moved anteriorly. And depending on the grade of the anterolesthesis, we decide how stable the spine is. So if you're graded 3 or more, usually what we recommend is that an opinion of a surgeon to stabilize the back. Before the 3rd grade, we can offer injections, and those injections would be beneficial of controlling the pain, and then physical therapy. And physical therapy is important to restore the muscles of your back, and that might be one thing that would prevent the listhesis forward. But if it's past a grade 3 of anterior listhesis, at that point we think about, a surgical option.
Helen, do you know what grade you've received?
It's grade 2. It's a 6-millimeter.
So that's kind of like borderline for which patient can do a trial of conservative treatment between physical therapy and injections. And if that was helpful, patient can continue that as long as the listhesis did not extend or did not proceed to a higher grade.
So Helen, it sounds like that might be an option for you. Good luck with your situation. You're watching Hello Health on WLAE. We're taking your calls and questions tonight at 504-866-3200. Let's go to New Orleans, where Cindy is holding on line 6. Cindy, welcome to Hello Health.
Hi.
Hi, Cindy,
Hi, this is Cindy Delane. I live in Houston, Texas. I just happen to be here now, and somebody who knows my chronic pain and my story told me to watch. I was a stage 4 cancer survivor. I had central nervous system lymphoma in my back. Good news, I survived. It's been 7 years, but my pelvic pain is unbearable. I've done actually everything you've talked about, plus I've had a pain pump, 2 spinal cord stimulators. I've had, the injections of the steroids. I've done 3 trials. I've done all of those things. I have not done the radio frequency ablation. Is there a chance that could help me when these other things have not?
Well, Cindy, it all depends on what's the cause of the pelvic pain. So if the sort of the cause was related to arthritis, or arthritis specifically related sometimes to the SI joint, at that point, that might be helpful doing the ablation. But if the cause of the pelvic pain was related to neuropathic pain or nerve pain, usually we conserve to modality that you had, like a spinal cord stimulator, or a higher modality of having an intracecal pump, which you might have mentioned that you had already. Now there are newer techniques coming out, and we're going to discuss about that, where conventional spinal cord stimulator have failed. Those newer techniques coming out, which are not FDA approved yet, but very, very soon will be FDA approved, that is really more of a successful control of neuropathic pain. So coming back to your question, I think if the pain was related to arthritis, radiofrequency ablation would be a very good option. If it was not related to arthritis, we would still reserve to neuromodulation or intracecal pump. Other way, if the if the pain was related to cancer is that we can do nerve ablation that's not radio frequency. Actually, it is nerve ablation using phenol or alcohol to the sympathetic nervous system, and that would grant people some relief. We usually do a block for it first. We inject local anesthetic to see if the patient had relief, and if the patient did, we go ahead and do the ablation procedure, and that's for the aim of a prolonged period of relief.
So Cindy, it sounds like there may be some hope here in the short term, and maybe more hope down the line. We're happy you're in New Orleans, and even happier you're watching Hello Health tonight. Thank you for your call. Let's go to line 1. Gertrude calling us from Pearl River this evening. Gertrude, you're on with Dr. Magid Guirguis. Go right ahead.
Okay. Doctor, I appreciate you taking my call. I have had a lot of back problems. I've had 5 back surgeries. I have had 3 neck surgeries. I've had the bone stimulator put in. I went through that. I went through injections in my spine. My tailbone has a cage around it. And I have been suffering so bad. No one knows the pain that you go through when you have a back like that. Is there anything you can tell me that would help me?
So again, I think in last modality pain, people specifically who had multiple back surgeries, I mean, a spinal cord stimulator is a good modality for treatment. There's some difference between a bone stimulator or bone growth stimulator and a spinal cord stimulator. In the case of people having surgeries all the way up in the neck and in the lower back, there are new devices that would put more than one lead or more than one device in the body that's hooked to a spinal cord stimulator. If the spinal cord stimulator, which is used here as a last resort, was not really enough for pain control, sometimes the other option is actually putting a pain pump in and using multiple medication in that pump. People would have relief, especially if it's after extensive multiple surgeries for which everything else was tried and could not have a good pain control. So I think the options is between newer stimulator or newer modality of stimulation and intracecal pump used as a last resort. Now, when you review a case, you can also see that there's always a process of arthritis that's missed that can be treated with either very simple injection to those facet joints or not. And I have seen a lot of people that would come in after extensive surgery, and the problem actually is not the surgery, it was some small joints causing arthritis. I get a lot of neurosurgeons also sending me patients that complain of a different pain after the surgery, and that's arthritis, which is expected once you have a metal cage in your body, that the level above and level below that cage become more accelerated in arthritis. And that might be, for the patient, might feel like the same problem, but it's a different problem.
And there are treatment options and other treatment options.
Those are other treatment options for arthritis, including the ablation or joint injections, or a different medical management approach that some physicians don't think of because you come in with a cage in your back and everybody relate the pain towards the surgery. So, before we actually jump into a last resort treatment, we usually do a comprehensive evaluation first and see if the pain is truly coming from those multiple surgeries or not.
Gertrude, thank you for your call. I hope the doctors offered you some help and some hope, and it sounds like you need it with everything you have been through. Let's go to line 2. Merwin is next, calling us from Metairie this evening. Merwin, you're on with Dr. Guirguis. Welcome to Hello Health.
Hi, this is Merwin Angel. I have been suffering chronic jaw pain, and I had in the hospital surgery where they go in and he did some laser treatment, cutting in the jaw area, in the joint area, and that didn't seem to do much good. And then I also had a procedure done in his office where they go in with the little probes and clean out the jaw joint area, and that didn't help any. And all surgeons seem to say that I had like bone degeneration and inflammation. And I was just wondering, he said the next thing might be like a jaw joint replacement, similar to, you know, on the line of a hip replacement. But I was wondering if there's anything y'all have available for like chronic jaw joint pain.
So chronic jaw pain, if it was related to arthritis of the temporomandibular joint, the usual treatment for that between comprehensive management is jaw injections or steroid injection, which, you know, in your case might be helpful, or, you know, if you're already going for a replacement, it might be beyond the steroid injection. So if the steroid injection did not usually help, we recommend the follow-up with, you know, a maxillofacial surgeon. Very few cases reported that they use the spinal cord stimulator for a peripheral field stimulation for jaw pain. I have not seen any of those coming here from the U.S., but some came from Europe. Equivocal, like, you know, like 50-50 chance of people getting some relief of those, but that is an option that might be available in the future for people specifically for joint pain that we cannot inject or replace.
All right, Merwin, thank you for your call. Our phone number is 504-866-3200, 866-3200. We'll put that at the bottom of your screen for you to take a look at. You can also send us questions by email at hhquestions@wla.com, and most of our physicians are very helpful in helping to answer those emails, even if we don't get to them this evening during the program. We've had lots of calls. Let's go to line 4, but we do have some lines open. Gloria is next, calling us from New Orleans. Gloria, you're on with Dr. Guirguis. Welcome to Hello Health.
Yeah, hi.
Hi there.
I had a total hip replacement in 1972, and I'm 82 years old. I went to the doctor, and he told me that he could do nothing for me at this time. The hip has come out of, you know, replacement. And at my age, at 82, with health problems, is there anything that you could do for me with the pain?
So actually, thank you for calling, Gloria. Actually, the new modality of radiofrequency ablation that I was talking about for the knee, which we used for after replacement of a knee, are being used right now also for after replacement of hips, where they find the nerves that are causing the pain from the hip, and we first block them and see if that helps you. And if that was that helped to control the pain, or those injections helped at the beginning as a test, then we would use the same technique to insert needles and ablate those nerves. And those case reports are coming with very good results for the hip radiofrequency ablation. For that, we use a specific type of radiofrequency called the cooled RFA. And the whole idea about the cooled RFA, actually, Tom, is that instead of giving you a small ball of fire at the tip of the needle, we give a bigger ball of fire, which guarantee you to get those nerves, especially after a replacement where the anatomy has changed. So we follow that with stimulation, and once we decide that that's where the origin of the nerve causing the pain is, we just ablate it or burn it. And expectation is 6 months to 2 years of relief, again, similar to all the ablation done either in the back and the knee.
Wonderful. Very good, Gloria. Thank you so much. And Doctor, I had a question about, 6 months to 2 years. In most of these procedures, and I know in steroid shots, maybe not right away, but how soon do you know, and how soon does the patient know if it worked or if it didn't work?
So regarding the nerve ablation, usually once the soreness from the heat subside, which is about 48 hours, the patient would know that, that the procedure actually started helping with the pain. And it would, the destruction by the nerve itself leaves some soreness from where the scar tissue occurred, and that takes about a week for which the patient would feel the peak of relief. So the relief would usually start within 48 hours and peaks within a week. And the hope is that those nerves would not regenerate as fast as we expect. I mean, I always tell the patient, I hope you're the slowest person for the nerves to regenerate, because they only carry pain signals. So the slower they regenerate, the longer the duration of relief you get.
And when those nerves grow back, does the pain return slowly? Or does the pain, or am I in no pain or very little pain, and all of a sudden I'm calling you on the phone going, doctor, I've got to see you, the pain is back?
Usually it returns back slowly, but it's all theoretical about how the pain comes back, because we have seen people that got those ablation and they say the pain never returned. And definitely those nerves has regenerated. But where the patient in those months where he got the relief, where he became more active, to an extent the prognosis of the arthritis or the progress of the arthritis was minimal. So that's the reason why the patient had relief, which I really hope they had the relief forever. Or was it something that we don't know? And I mean, all of this is still subjected to studies. And I have a couple of patients that required the radiofrequency ablation one time. I mean, and I've seen them for a couple of years, going back all the way for where I did my residency. And I saw them through fellowship, and you know, some of them I still keep contact with, and the pain never came back.
And no problems with you. You're not in any hurry to see them, right?
Yeah, no, I'm
just
not.
Just keep in touch, right?
Yeah.
Okay, let's go back to our phone lines. Line 6, going to Chalmette next. Mike is next. Mike, you're on Hello Health.
Thanks for taking my call.
You're welcome, Mike.
Okay. About 6 weeks ago, I had sort of a freakish accident happen in my home where I actually stepped on my cat, and then immediately shifted my weight to my other foot and had a terrible pain go from my buttocks area down my leg. And saw my doctor about it, been on some pretty conservative treatment with medication, and been going to physical therapy for a couple of weeks, doing some different stretching exercises and things like that. But the only time it really, really seems to hurt me is when I sit. I can't seem to sit without getting a terrible pain in that piriformis muscle area and down into my hamstring.
Okay.
What could that be?
So, Mike, it actually could be a different number of causes, and for that, I think, you know, more investigation or a very good, proper physical exam can actually minimize those differential diagnosis. But having the pain really bad when you sit down make me always think about either a sacroiliac joint problem or a piriformis syndrome, which actually is a muscle that in 15% of the population, sometimes the sciatic nerve passes through that muscle. And when people overstretch that muscle, sometimes they get this known piriformis syndrome where they have pain shooting down their leg. But all of this is like, you know, that we would not really figure the diagnosis without a very good physical exam and maybe requiring some images to make a differential, because at the end of the day, sometimes it is still a herniated disc, but usually herniated disc which would have this pain shooting down the leg when people are active or actually, you know, really stretching or irritating that nerve root against the disc. So when the patient mentions sitting is bad, I always think about SI joint arthritis or piriformis syndrome if they mention shooting pain down the leg.
And would Mike start with a primary care physician, or would he go right away to someone such as yourself?
So the majority of the time we would like patient to start with primary care physician, because sometimes it's only a muscle strain and it really goes away with some muscle relaxant anti-inflammatory medication. But if the patient, like primary care physician, well know about a radicular symptoms or a sciatica presentation. So if they present with a typical sciatica, usually the primary care physician would send them to us right away, or surgeon depending on the case if it was very severe. But usually for an injury or a strain, for a patient who never had a back surgery or never had a back problem, usually they start with conservative therapy, and that's what I recommend. Actually, I always recommend conservative therapy first, and then intervention comes second.
All right. Thank you, Mike, and we hope the cat's doing well. Let's go to line 1. Alfred is next. Running short of time here, but Alfred, thank you for holding for your patience. Alfred calling us from Marrero. You're on with Dr. Guirguis.
Hi, thanks for having me on. 2 years ago, I had a stroke. I had a blood vessel break in my brain, and it's causing pain through my whole left side. That was paralyzed. I was wondering if there's anything I could get done or done to relieve some of the pain that I have, besides taking morphine.
So actually, Alfred, the recommendation, this is called central pain syndrome, and it is a tough situation, and it is very difficult to treat, but between medical management that's actually a non-narcotic management, more of a nerve or a pain modulation management, which is a variety of medication that can help the patient. Recently, neurostimulation has been helping with central pain syndrome. And it might not cover the whole area where the pain is, because the pain is really diffuse in that case, but at least it can cover some of the, at least the lower portion or the upper portion, depending on which is severe. Newer medication are emerging, and they're being used in Europe, and we're using some here right now. One of those medications that has been helping central pain syndrome is also known as ketamine. And there's certain places across the country that can do this as an infusion, which helps central pain. And we're hoping that very soon we get FDA approval about nasal ketamine that can also help with that pain. So between spinal cord stimulator and nerve or pain modulation management, I think that can help with the central pain syndrome.
Very good. We've got about 1 minute left, and I promised I'd ask you this question. I think you've tipped us off on a few things already, but if I have you back here 3 to 5 years from now, and hopefully it won't be that long, what are we talking about? What kind of breakthroughs do you see coming, and what sort of hope can you offer patients who are in chronic pain?
So I think, Tom, the future holds for neuromodulation or spinal cord stimulation, and I think that it has evolved a lot since it was, since actually the gateway theory for it was ever discovered in '65. And I think at that time, like in the future, neuromodulation was gonna be a standard of treatment of some syndromes of chronic pain or particular causes of chronic pain. And it would be implanted in a lot of people, and we're gonna be talking about it as a very simple office procedure that is done to patient day in and day out. I can see already at least three new modulation or ways of modulating the spinal cord waiting for FDA approval, between the way we send those electrical impulse or the way we put those electrical wire in the back, or actually newer electrical wire being used in the back. And all of this is, I think, would be FDA approved before 2017. Some of them has been used in Europe already. Some of them is waiting to be used in Europe and getting FDA approval. And that's where I see the future holding. I think neuromodulation is going to be the answer.
Well, and must be exciting for you as a physician, and I know exciting and offering hope for patients who are watching tonight in severe chronic pain. Dr. Guirguis, thank you so much for being with us.
Thank you for having me
Appreciate
today. Thank you, Tom.
Fascinating hour, and hopefully we have offered some hope and information, and I thank the doctor for the education and information he's provided here tonight. To make an appointment with any Ochsner physician, including tonight's guest, or to register for any of Ochsner's Hello Health seminars, they take place almost every week across the greater New Orleans area, you can call this number, set up just for viewers of this program, 504-842-5669. That's 842-5669. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website, WLAE.com, or on Ochsner's website at ochsner.org. Our thanks again to tonight's guest, Father Magid Guirguis. Thanks to Humana and Ochsner for making this program possible. And our final thanks, as always, is to you for your support of this program, Hello Health, and this station, our station, WLAE. Good night.
Hello Health on LAE has been presented by the Ochsner Health System. 850 physicians and 90 medical specialties working with a team of more than 13,000 employees provide nationally recognized healthcare across Southeast Louisiana. Oxnard, healthcare with peace of mind.
I call it my one less thing to worry about plan. With a Humana Medicare Advantage health plan, I get more clear information about my options with 24-hour access to my Humana, my secure website, and I can get help every step of the way from a Humana Market Point representative.
More of what you want because you deserve more.